Welcome, everybody. It is Friday, February 23rd, and we're here for another Florida EMS webinar. We have an amazing guest who's been on the show before. Eric Jaeger is from New Hampshire. He is a man of many talents, an RSI paramedic. He is an attorney, and he has really been very educational to us on many different points in the pre-hospital setting. And for those of you who are at NEMSP this year, Eric gave a series of talks on this topic. He showed some incredible videos, and it really stirred up a lot of buzz. I think this was maybe some of the most popular talks of the entire conference, especially after what happened with the folks in Colorado. There is no better time to hear all of Eric's advice and insight. So without any further ado, Eric, thank you so much for joining us. If you want to make any further introductions, and my friend, take it away.
Thank you so much, Peter, for having me on the podcast. This is a topic that I'm fairly passionate about. I've been on the webinar once before talking about death in custody, where we primarily focused on pathophysiology. I think of this talk, we'll briefly reprise that piece of the conversation, but I think of this talk as sort of part two. How do we address it? How do we work with our paramedics and EMS colleagues to ensure that we can reduce the risk of this happening again? Some key points: we have misapprehended the danger of physical restraint and death in custody. This creates a risk not only for our patients, but also for EMS providers and law enforcement. I think it's time to upgrade chemical sedation of the agitated patient. We should begin to treat pre-hospital chemical sedation as a procedure like RSI, which over the decades we've enhanced, building in safeguards like pre-ox, apneic oxygenation, and push-dose epi to help enhance the safety of that procedure. We are going to be discussing and viewing some video clips of tragic incidents where patients died. I just want to give people a quick warning. I'm always remind people when I show these video clips that it's not for me or for us to judge the actions of the paramedics and other individuals involved in these tragic deaths. Instead, really the goal here is to learn from these incidents to keep future patients and EMS providers and law enforcement safe. And I think that's a key perspective when talking with EMS and law enforcement community. I am going to first mention Elijah McClain, which Peter mentioned. Elijah tragically died in Aurora, Colorado in August 2019. He was walking down the street minding his own business. Police were called by a 911 caller who said, "Hey, I see a guy who looks kind of sketchy, might be good, might be bad." Elijah hadn't that night committed any crime or any night. Elijah wasn't on drugs that night or any night, but police attempted to take him into custody. They restrained him for an extended period of time on the ground. EMS arrived. While he was restrained, they administered 500 milligrams of ketamine. He's reported as having been unconscious when they moved him to the stretcher, and he suffered a cardiac arrest in the ambulance. He was resuscitated, but ultimately died from anoxic brain injury. This is the headline Peter was referring to. The trial of the police officers were on trial last year, and one of them was found guilty of criminally negligent homicide. And the two paramedics, their trial concluded in December of this year, and both paramedics were found guilty of criminally negligent homicide in the death of Elijah McClain. This really has sent shockwaves through the EMS community because, sure, we see paramedics criminally charged from time to time. They assault a patient or do something else clearly inappropriate. Here, this was really more, these guys were charged with criminally charged for violating their protocols is really what this amounts to. And that resulted in criminal charges. And these guys are going to end up going to jail. So it's really raised some questions that I'm not going to have a chance to address today from more a medico-legal perspective, how this impacts paramedics operating in the street. I want to tell you about another individual, though, who didn't get as much press and who died just a month after Elijah McClain. James Britt died in Mount Pleasant, South Carolina in September 2019. You can see James Britt right there. He's a big guy. He was driving down the street intoxicated, curbed a tire, pulled over, tried to change his tire. The police came on scene. Very polite interaction initially, but he's eventually told he's going to be arrested and his car impounded, and he gets upset. So he's restrained on the ground by police, as you'll see. Because he's intoxicated and obese, he struggles to breathe adequately. Paramedic administers 500 milligrams of ketamine. He's kept in the prone position until he's unconscious. When lifted onto the stretcher, he becomes apneic. Paramedics fail to appreciate the danger. He, just like Elijah McClain, suffered cardiac arrest and later died of anoxic brain injury. And these two are not alone. These also haven't seen as much press, but there's at least 6 other patients that have died in similar circumstances, each of these involving EMS administration of ketamine. So key questions, what is causing these deaths and what changes need to be made to protocols, training, and leadership to reduce the risk of future deaths? I am going to talk briefly about the pathophysiology of death in custody. For years, we focused on excited delirium, excuse me, as the cause of many deaths in custody. We trained paramedics on it. We built it into protocols. In 2021, the AMA, committee of the AMA came out with a report that took a hard look at excited delirium and said excited delirium and potentially fatal restraint are inextricably interwoven. Restraint was described in 90% of all excited delirium deaths. There is no evidence to support excited delirium as a cause of death in the absence of restraint. Since that time, excited delirium has been rejected soundly by most major relevant medical organizations. This includes the AMA and the American Psychiatric Association. Most recently, this past year, by the American College of Emergency Physicians, who were really the ones who issued the white paper in 2009 that led to, in part, EMS adopting this concept of flawed concept of excited delirium. In addition, the major medical examiner organizations, the National Association of Medical Examiners, and the College of American Pathologists have actually rejected excited delirium as a legitimate cause of death in death investigations. You know, we talk a lot about the ketamine overdose. An enormous amount of attention has been focused on the allegation that the Aurora paramedics administered an overdose of ketamine to Elijah McClain. Elijah weighed 140 pounds. The correct dose for him was probably more in the 300 plus milligram range. And this was a central contention in the criminal trial of the 2 paramedics. I think, though, there's a real question whether there's actually a toxic dose of ketamine, and Peter and I were talking about this before we came on to the talk, but there's a study out there that looked at ketamine overdoses in kids receiving procedural sedation. They received 5 to 100 times the intended dose of ketamine, and no one died in any of these cases, no adverse effects. They simply remained disassociated for longer. So, and maybe there's some wiggle room on this. But there is no, as far as we can tell, no toxic dose of ketamine. Ketamine in and of itself is safe even at higher doses. So if that's true, what killed Elijah McClain and James Britt and so many others? I'm not going to pretend that I'm a forensic pathologist or pulmonologist and that I definitively know the answer, but it has become pretty clear that what's killing these individuals is positional asphyxia due to prone positioning with weight on their back for an extended period of time. While restrained prone on the ground, their conscious struggling fight or flight sympathetic surge is keeping them alive, maintaining an adequate tidal volume and minute ventilation. Ketamine doesn't stop your breathing, but what it does is it obliterates your conscious struggling. As a consequence, their breathing slows, their tidal volume decreases. Held on the ground for minutes longer, they become profoundly more hypoxic and acidotic, and eventually they tip over into cardiac arrest. This is a video that is much more recent than Elijah McClain and James Britt. I'm going to show you this. This is Trey Ellinger. He died in Baltimore, Maryland in July 2023. And I have to tell you, this video is almost, in some sense, more disturbing for me than the other videos, in part because this is 2023. We've been learning the lessons from George Floyd and Elijah McClain for the last several years. I think we've started to become aware of the dangers of prone positioning. You'll see in this video, the police try and keep Trey out of the prone position, and the paramedic is alert to the fact he shouldn't allow Trey to be in the prone position, and yet somehow Trey Ellinger still ends up dead after receiving ketamine from EMS. Let's watch.
Yeah, where's I going that way? I lost it. I took the hand of black people. But no, I don't want to say that. I do not want to say that. Yeah, they go.
It'll help. All right, sir. It's okay. We're here to help you, darling.
Yeah, just kind of put him in a daze. Okay.
This is his, right?
Yeah. That's what he said. What'd you say? All right. It's not going to change for about the next 4 minutes. But we can start moving to you guys.
Hey, you still not a smooth.
At least y'all got
Stop fucking out of me.
All right, so... And as long as he's not laying face down like a break.
Yeah. Well, he's... I'm going to get him up here if y'all can...
Nah, if you wait 4 minutes, it's going to let 4 minutes kick in. He's going to keep spazzing. All right, so y'all want to pick him up? All right, one.
Come on, guys. Oh, God.
It's okay. We're trying to help you, okay? We're trying to help you, okay?
I don't know what that is, bro. It's like apple pain.
It's okay, darling. It's all right. It's okay. It's all right. It's all right. All right, y'all want to get him?
If I pick up,
They're like 6
Absolutely. All right. Absolutely.
Okay, Merlin check. 5 PM, 536.
Am I riding with the back or just follow? No, you ride. You get your vehicle. I'll ride.
I got a wallet that came from...
So my question is, what went wrong there? And just to be clear again, I want to restate that I'm not criticizing these paramedics or the police officers. I watched the whole video. I think the police officers were trying to help Trey Ellinger. I think the paramedic had no ill intent. This again is just about what can we identify that we can work with our EMS teams to avoid this kind of problem occurring. I should mention, so Trey Ellinger is loaded in the back. You can see in the prone position, he goes into cardiac arrest. They attempt to resuscitate him, and just like all the others, he ends up dead from an anoxic brain injury. So questions I have when I watch this video are, was chemical sedation even needed here? We've told our medics over time that if they're going to physically restrain someone, they should probably use chemical restraint as well to prevent them from struggling. And I wonder if that advice to paramedics lacked nuance. An individual like Trey Ellinger was going to get transported 5 minutes down the road to a Baltimore hospital. He didn't look like he was all that agitated. Could he simply have been restrained to the stretcher? I see no physical assessment being, and this is where we start to talk about, you see the paramedic come up and administer the ketamine, and it's really a med administration from his perspective instead of a chemical sedation procedure. No physical assessment was performed, no vital signs obtained before the administration of ketamine, and we see this over and over again in these videos. The paramedic is not focused on his patient immediately post-sedation. He sort of steps back, he's chatting with people, kind of waiting for the ketamine to kick in. One of the things we've come to understand about ketamine is great drug. And just to be clear, I support its continued use by EMS. I think when used properly, it's safe and effective. But that's part of the challenge with ketamine. It works so quickly and so effectively that I think medics that are used to giving benzos or antipsychotics like Haldol are used to a sort of a slower onset of effect. So here the paramedic loses focus on his patient. There's no equipment. Because there were no vital signs taken and no equipment at the patient's side to assess him, there's now no equipment for performing monitoring or resuscitation when sedation is performed. The admonition to avoid prone restraint isn't followed, so the paramedic and one of the police officers said, just don't let him go prone. And you watch, they put him on his side on the stretcher, and then he sort of kibbies down into the prone position, and the paramedic tightens the strap across his back. Why is he tightening the strap? There's no ill intent there. He legitimately doesn't want Trey Ellinger to fall off the stretcher. And yet Now Trey is prone with a strap across his back that's going to make it difficult for him to maintain an adequate minute ventilation and tidal volume. And I watched that video dozens of times, asking myself, why did the paramedic, after having articulated he didn't want Trey Ellinger to be prone, how do you allow him to go prone and stay in that position while he got loaded in the ambulance? The answer I came up with is the paramedic thought, you know what, I'll fix it when I get in the back of the bus. I'll just load him in the back and we'll fix it there, which is sort of a common way for paramedics to approach this situation. Instead of, hey, this is a real danger zone moment, I need to get him out of that prone position. And then I think there's a failure by the paramedic to appreciate how suddenly and precipitously death can occur. So what can we do to do this differently? I propose there are 10 key principles to enhance the safety of restraint of the agitated patient, and I'm going to share them with you here now. I want to be cautious. I don't suggest that following these 10 principles makes physical restraint inherently safe. Physical and chemical restraint always carry some risk. In New Hampshire, we've now rebuilt, we're about to launch our new restraints protocol that we built around these 10 principles. The overall concept is that we should be treating chemical sedation much like we treat RSI. Over the years, we've increased the safety of RSI, but, by building in safeguards. Resuscitate before you intubate, proper positioning, pre-oxygenation, constant monitoring, 2 airway providers, etc. I think it's time to give pre-hospital chemical sedation an upgrade. Principle number 1, prone restraint is inherently dangerous. Never restrain in the prone position for an extended period of time, more than 1 to 3 minutes. This creates a severe risk of ventilatory compromise that results in hypoxia and acidosis. Death can occur suddenly and with little warning. This is Mario Gonzalez. I'm going to show you just 2 very brief clips. The first one is really just to introduce Mario, who Mario clearly is on something. He's in a park in Alameda, California. He died in April 2021. So this is Mario Gonzalez. I'll show you a brief clip to introduce Mario, and then you'll see what happens when he's taken to the ground. No ketamine involved here. This is just the police.
Okay. Was it Mario? No. Hey, do me a favor. There's something here, okay? There's something here. Hey, come over here. Come over here.
So that's Mario, and here's his interaction on the ground.
Mario, calm down, please. Stop kicking, Mario. Stop.
So you hear Mario grunting. Mario has additional problems. He's obese. He's on something that's going to make his struggles to maintain an adequate minute ventilation harder. He's grunting, probably trying to get oxygen into his lungs. You hear the police officers say, Mario, stop struggling. None of these individuals can stop struggling. They're all struggling not to get up and punch the police officer. They're struggling to get up and be able to breathe.
Stop kicking. Look at the color of his fingers, too.
What's that?
Look at the color of his hands.
Yeah.
You can see. Yeah.
Oop.
Mario, calm down, please. Stop kicking, Mario. Stop kicking. Okay. Think we can roll him on the side? I don't want to lose what I got, man. Okay. Can you grab the wrap out of 111? Mario, just please stop fighting us.
It's all right.
We have no weight on his chest.
Can you go around there?
No weight.
Everybody else go.
He's going on unresponsive.
Copy you.
Mario.
910 can slow down.
Mario.
So Mario, of course, is not unresponsive. Mario is dead. These guys do the right thing again. They immediately put him on his back and begin CPR, albeit with handcuffs on. They call Alameda Fire. Resuscitation is attempted, and just like in all of these cases, it's unsuccessful. And you saw, I didn't want to pause it again because I didn't want to screw it up, but you saw they're conscious and aware again of the risk of prone restraint. One of the police officers says, hey, can we roll him up on his side? And the other one says, no, I don't want to lose what I got. You hear them say, we have no weight on his back. And clearly when the camera pans back, you see there is weight on his back or side, which is pressing him into the ground, right? And so part of what worries me about the training that's already been occurring for police and for EMS is we're focusing on a couple of pieces of it, like the prone restraint and getting them up on their side, and not focusing on the bigger picture. It's also startling how quickly Mario just suddenly becomes silent, and at that moment he's in cardiac arrest. There's no time to sort of react to it. So that's prone restraint. Principle number 2, only proceed with chemical restraint if the patient is an active threat to self or others. That determination should be made only after attempts at de-escalation have been unsuccessful. A patient who is physically restrained and not actively fighting is not an active danger. Number 3, never administer chemical sedation at the direction of law enforcement. I think we're pretty clear in this one now, but the decision to administer chemical sedation is a medical decision made by the provider based upon clinical judgment, should not be influenced by the police or any other agency. Number 4, before proceeding, identify and treat any potential organic causes. Combativeness may be due to hypoxia, hypercarbia, hypoglycemia, drug and/or alcohol intoxication, or brain trauma. In the case of Elijah McClain, he wasn't agitated before he encountered the police. He only became agitated after they held him on the ground and he became hypoxic and acidotic. This is Dr. Melissa Costello. She looked at Elijah McClain's death for the city of Aurora. She asked the question, what should the providers have done after gaining access to Elijah McClain? EMS personnel should have initiated at least a primary assessment and conducted a brief hands-on evaluation. And she's aware that because he was agitated, you can't do a full assessment, but she still said no assessment was done and they should have attempted to assess their patient. Number 5, beware unconscious and anchoring bias. Our unconscious assumptions negatively impact the care we provide, and these impact us most in stressful or ambiguous situations like wrestling with an agitated patient. It's hard to address unconscious bias, and it's a much larger conversation that we've begun to have, but advise providers to slow down, be systematic, and that's how turning this into a procedure is helpful. And then many agencies are now implementing an independent observer, such as another supervisor or paramedic when chemical sedation is going to be done, who essentially oversees the safety of the procedure. Number 6, consider an alternative agent. Ketamine is intended for severe agitation. Droperidol is increasingly being used as an alternative. For moderate agitation, consider droperidol or Haldol and a benzo. For mild agitation, a low-dose benzo may be enough. So scale the agent you're using based on the actual situation. 7, never, and I don't use that word lightly, never administer chemical sedation to a patient in the prone position. Reposition the patient to ensure their airway and breathing are not restricted before proceeding with sedation. Administering ketamine to a patient restrained in the prone position carries a profound risk of death. In RSI, we say resuscitate before you intubate. Here, we should be saying reposition before you sedate. Number 8, all monitoring and resusc equipment must be at the patient's side. That doesn't mean in the truck 25 feet away, just like you wouldn't do an RSI on the ground without all of your monitoring and resusc gear right there. This includes equipment to monitor heart rate, pulse ox, end tidal, etc., and resuscitation equipment, including a non-rebreather mask, BVM, etc. Dr. Costello also addressed this and found the failure to have monitoring resusc equipment at Elijah McClain's side was a factor contributing to his death. Number 9, during sedation, the provider must be laser focused on monitoring the patient's airway, breathing, and circulation. Treat chemical sedation like intubation. Both are high-risk procedures that require providers' undivided attention. And I said 10, I actually have 11, so I have a 10A and 10B. 10A, obese patients are at increased risk of apnea. Their weight exacerbates breathing difficulties. And 10B, alcohol and sedative drugs create a severe risk of apnea. Chemical sedation eliminates a patient's sympathetic drive, leaving the depressive effects of alcohol and sedatives unopposed. I've had multiple paramedics tell me about near misses, in particular with intoxicated patients who they gave ketamine to and who suddenly became apneic. And in all those cases, fortunately, they picked it up and immediately began bagging the patient. But if I can have encountered 4 or 5 individuals with near misses, I know there must be many more out there. That's really what I had for you. The take-home points are prone restraint is inherently dangerous. Ketamine is safe and effective when used appropriately, but it should never be administered in the prone position. Even IM ketamine may cause apnea or may cause laryngospasm, especially for patients who are intoxicated. You enter the danger zone when administering to someone who is hypoxic and acidotic. Safe use of ketamine means only when there's an active threat, only when medically indicated, with the correct dose, assessment conducted prior, all equipment needed for monitoring recess of the patient's side, and medic focused exclusively on the well-being of the patient. Thank you very much. Reach out to me at my email address. All of my presentations and these videos are accessible online. I have them up on a web page, and my goal is to facilitate training by others with their jurisdictions. I think we need a new sort of national curriculum focused on this, but I'm trying to do what I can. Reach out to me if you're interested in virtual training, and I am happy to also look at people's protocols and review them and give you feedback. Thank you so much for your time.
Wow, that's phenomenal. Thank you so much for those offers. Amazing talk, and I love those 10 principles. We only have a few minutes. I want to bring in a few people. First, Dr. Shepke. So Ken, are you there? And then I want to bring in Doug Kupas. So Ken, started the use of ketamine here many, many years ago when we had Flocka down in South Florida. And he always tells the story, I'm not sure if he's on yet, but he always tells the story of, because Palm Beach County was using ketamine and Broward County wasn't, there were many more deaths in Broward County where ketamine was not being used. So it goes to your point, Eric, that the correct use of ketamine is life-saving. So Ken, I don't see Ken coming on, but let me bring in Doug Kupas. So Doug's done a lot of work at the national level, looking at definitions, etc. Several papers have been published, and he's put those in the chat. So Dr. Kupas, would you mind coming on and just giving the crowd an update on some of the terminology that you've put out with the group?
Yeah, sure. And obviously I have a little conflict because I'm the primary author of that position statement that I put in there, but I was also the primary author of the 2002 one. And after the incidents in 2019, we updated that and brought in more organizations like NASEMSO and NAEMT to that joint position statement. I think, it has a lot of the points that are made here. I think Eric did a terrific job of summarizing these issues, yet we continue to see, that the word is not getting out. So, the importance of connecting preemptively with EMS and law enforcement to make sure that everybody's on the same page, the extreme importance of the patient assessment. But I think one of the things that strikes me is that, we use the term delirium with agitated behavior because many of these patients that get into trouble are not delirious. They're saying, in the Elijah McClain case, when he was restrained on the ground and retched, and the police were making comments about, not doing that, he was saying things like, "I'm sorry, I didn't mean to do that." He was not delirious. And I think that initial assessment of just getting down and talking with the patient and assessing whether they're delirious or whether they're just, somebody who has the wherewithal to be understanding, but they're just an uncooperative person. And I wouldn't say he was that either. I mean, the Elijah McClain case is really a sad case. So those are I think the key things that I see in there. And we need to keep pointing to the position statements and education. And the last point that I put in there was, an emergency medicine resident needs to see and do 32 sedations before they're able to be viewed as comfortable with that. And I think we train a lot of the EMS practitioners, or at least I'm aware of some training that some have gotten, where they get an hour on, here's this new medicine we're putting in, you use it, it's safe. And they have never even seen a controlled sedation in an emergency department with the monitoring and types of things that are done, and to fully respect how many of these patients get hypoxic and you need to intervene. And I don't think that is, we're doing a disservice to our practitioners by not emphasizing those things.
Sorry, Peter, I was offline a moment ago, but I'll just add very quickly, Eric, fantastic presentation. I think we're going to kind of probably R&D a lot of that because I think it was phenomenal. But Peter, you're absolutely right. We put in ketamine years and years ago. We had that Flocka epidemic in Broward and Palm Beach counties. And you've heard me say this before. If you asphyxiate the patient, it doesn't really matter what you use as a sedation. You sedative, you're gonna have a bad outcome. So when we rolled it out, we met with our police officers all over the place, and we made sure that all this business about prone and allowing patients to hyperventilate, et cetera, was absolutely mandatory. And I think that's part of the reason why we've had such good success with it, is because we had that as a partnership with our law enforcement. So they were educated years and years ago before this became like a national issue. The other thing I would say is that you're absolutely right that you should be saving the ketamine for the most extreme cases. This argument we're all having about excited delirium, is it a real thing or not? I mean, you can go all the way back to the 1970s when Johnny and Roy were on TV and they were treating a chemically induced psychosis. This is a clear metabolic issue. These folks have metabolic acidosis. I don't really care what terminology you put to that. That does not mean that everybody that gets ketamine has excited delirium or whatever term we end up landing on. But there is a real clinical phenomenon for patients that take a number of stimulants, whether it be ketamine, whether it be cocaine, methamphetamine, or Flocka, or a whole host of other things that can create this scenario with a severe metabolic acidosis, along with a delirium state and agitation and violence. That's not mean that everybody that's fighting us has that condition, nor does it mean that everybody needs ketamine that's fighting us. So I think you're absolutely right that this is not a one size fits all. It has to be tailored to the patient. And I love the idea of monitoring it just as if you're about to intubate someone in that type of procedure. That's exactly how we like to see it. And I think that's you put a good logical way of how we should roll this out.
Yeah,
Awesome.
fantastic. And I'd just like to say the whole debate doesn't exist. I don't even understand that debate. Of course, we encounter patients in that kind of clinical scenario where they're agitated and delirious and acidotic. Really, the excited delirium piece, just for clarity, is that construct in and of itself had some challenges with it from its origins that made it probably not the right way to think about these patients and may have caused paramedics not to approach these in an appropriate way. So it's a separate part of the conversation, but I absolutely agree that the clinical condition exists.
Excellent. All right. Well, we're a few minutes over, and I wanted to just thank you again, Eric. There is a link in the chat to pop over to Dr. Pepe's webinar on the Eagle, which is starting right now. But Eric, let me give you the last word. You had a lot of people. I think we had up to 50 people at one point during this presentation. You have EMS leaders on here. You have medical directors on here. What do you say to them as far as, you know, like what should they be focusing on in the next, let's say, month at their agencies?
I think
most critically.
I think that's crystal clear. I think they all need to go back and pull up their protocols and see whether their protocols are written in a way that promotes the concept of chemical sedation as a procedure rather than as a medication administration. I think they should go back to their EMS educators and ask them and explain to them how they want to approach pre-hospital chemical sedation as a procedure, and that they should rewrite their training, that we need to go back to our paramedics, except in cases where it seems some areas have been doing this training, and the training needs to be both classroom, and I can't emphasize enough how important it is to do hands-on simulation training with your paramedics. They're not going to get the 25 sedations that a resident's going to get, but I have now been doing simulation training with our folks locally, and I think it makes a dramatic difference to do that hands-on training with them. Thank you so much.
Wonderful. Wonderful. Thank you so much. Everybody, thank you so much for joining. This will be on YouTube later today, along with the other. I think we have over 150 talks, all EMS related, all with super bright people like Eric. Join us next week again. We have another great presenter. And if you see any articles out there that you think should be summarized by the author themselves, please just send them my way. I think I'm about 100% for authors who are accepting the invitation. So we can get the best and the brightest here, and we do it every Friday at 11. Thanks, everybody, and let's see you over at Dr. Pepe's webinar, where he's got some great guests as well. Thanks, everyone.
Thanks so much.
Eric, feel better, my friend. Thank you so much. You were amazing.